Hi, everyone. My name is Lori, and I'm with the Medify team, and I have the pleasure of introducing our last Medify presentation today. So this is managing alcohol in the community. We have Katie Dunham, who, if you've been here today, you will have heard her speak and know her background, but I will say it again.
No. Nurse practitioner. I work in Ontario. Nursing educator for Medify.
Nursing educator for Medify and works at Stonehenge and does amazing work. We need to clone her. She works 18 hours a day and she's... Okay, my battery's running low. Okay. Adam McInnes is a nursing team lead of addiction medicine at CMHA Thames Valley in London, with a Master of Science in Community Health from the University of Toronto, specializing in addictions and mental health. He has experience in both community and acute care settings, including Sherburne Health and CAMH, both of which are in Toronto. Adam combines his clinical expertise, his public health background, and lived experience to inspire hope and change, working alongside his clients and within the broader system of addictions care. And we're quite pleased to have Adam with us because he's got a lot of competing stresses, let's say, with school and work and conferences. So thank you. And finally, certainly not least, okay. Thank you, Jennifer. All right, take it away.
Maybe I'll see if I can just hold it like this. Welcome all to our presentation on managing alcohol in the community. I tend to move around and kind of go all over the place. That's why I'm bringing the mic off the table here. I'm a registered nurse. As was mentioned, I'm currently finishing my nurse practitioner studies. Halfway there, a year to go, 10-page paper next Monday. So I'm in and out of the conference trying to study, but I couldn't give up the opportunity to talk about this. So our presentation is on managing alcohol in the community. No speaker disclosures to disclose. This presentation uses generic names for all medications. In this presentation identifies off-label use, any use of a medication that is not mentioned in the product monograph. So what are the learning objectives for today? So first and foremost, we want to be able to identify appropriate patients and settings for outpatient withdrawal management, considering risks and resources. As noted there, we'll dive deeper into that in the presentation. Select suitable medications and doses for alcohol withdrawal management for home and ambulatory clinic and day settings, and improve transitions and supports between the various settings where patients receive care for withdrawal. I also have my own story. So as was mentioned, I do have lived in living experience. So I like to blend both my clinical work and my own story. Bear with me, I'll be tangential all over the place with this story. I'm tangential all the time anyways, even with my clinical work, but especially with my lived experience. I've also not really talked about it in this sort of setting. I've certainly talked to many nurses in the province, but this is the first time I've done it in this setting. There I am with a classic mushroom haircut. I was raised by a single mother. I was the youngest of three boys, and we had a very safe home, which was wonderful. I didn't feel like I was walking on eggshells when I went home. But we didn't have much money. We grew up in a lower socioeconomic kind of status. I lived in social housing, so I didn't have all the fancy toys as some of my friends, but I had a safe home, and that's what matters. Oh,
You can move around a bit.
oh, perfect. Awesome. Do I turn that on?
Yeah, I got that.
Awesome.
Sorry, I didn't mean to interrupt you there.
Check, check. Okay, so I'll keep going. So I like to move around in my presentations. I'm always fidgeting and moving around anyways. Thank you. And so I grew up, again, it wasn't, I didn't have fancy clothes or anything, but I had a safe home. And that was really the main thing. Okay. If you may have noticed, I have a few tattoos, and that kind of goes along with my story. And this connection to our piece is that I have a big family history of addiction, which a lot of people have. Both my grandpas here both had pretty severe alcohol issues. This is my grandpa McGinnis. He drove trains, noted here. So I have that tattoo over my heart because we're very close. For his story, he was able to stop drinking in his 30s, which was incredible. And he was kind and compassionate. But one time he told me, I was visiting him in Prince Edward Island. He said, "Not a drop of alcohol in this house." And that really stuck with me because he did not give direction like that. And when he said that, I certainly listened because he knew I was on that path. This is my grandpa Trentman. So he also had a severe alcohol use disorder. And at the same time, he was tremendously achieved. He was a PhD, an All-American athlete. He was the head of the arts department at McGill University, principal at Huron College at Western. And unfortunately, he died of this disease at a young age. So lots of connection with my story. And we know genetics, there's many pieces that come into play with addiction, but I certainly had that genetic component at hand. So there, these guys up here, and then I also have my father. And even though I was raised by a single mother, I also we reconnected with him later in life, and he would drink, and he'd smoke quite a bit. And when you put those two things together, we know as clinicians that's just a recipe for not such a good outcome. So he had head and neck cancer when I was about 15, and he passed away a year after when I was 16. And that started my journey onto alcohol. I was the youngest of three boys. It was a difficult time for me, and I was certainly the craziest out of the three boys. So I put my mother through a ringer. She actually did her master's in addiction studies, so I like to say I was a perfect case example for her. Okay, and so moving along, this is a picture of me and my two roommates. The gentleman in the white is Jeremy, he was in paramedic studies, and then on the other side we have Jake. He was in some engineering program, I can't recall. This was my second year of nursing school. And of course, I'm sure many of you can pick out, there's a nice beer in my hand right over here on the right side. These guys also have cigarettes, or darts as we would call them. And I probably have a dart somewhere over this way. This was 2 months before my first interaction with an emergency department for an alcohol-related presentation. Again, I started drinking heavily from 16 onwards, and I'm terrible at math, but maybe in the 20 to 24 range at this point. And now that I work as a clinician, I can kind of calculate how much I was actually drinking. And it was likely around 24 to 24 to 40 standard drinks a day, which is up there. I could have quite a bit. And again, I go all over the place, so bear with me. But the first presentation to the emergency department, I was psychologically very low, and my grandpa wasn't doing well health-wise, and I had harms and a plan in place to kill myself. And luckily, this guy right here, Jeremy, he came and checked in on me and called the appropriate services, and that was my first sort of interaction into the emergency department. That was a nice experience, as nice as you can make that sound, but I just remember there was a nurse, inpatient, who really got down onto my level, and I kind of describe it as like a deep cavern, where folks can be. At least that's where I was, and she lent out a very kind and compassionate hand, and just empathized with me. And I was talking about how I lost my dad, and like, this is why I'm drinking, and this and that, and my grandpa's not doing well, and she said, I lost my father too. And it just snapped. I still get kind of goosebumps when I recall that incident, because it really brought me out of that deep cavern of, this is just all me right now. There's other people out there, and I'm in the caring profession for a reason. And then second emergency department visit, I continued drinking after that event, which happens to many people. As we know, it's a journey. A lot of people return to their substance. But I had returned to my drinking, and as something you shouldn't do, I did, and that's go cold turkey. And I'm always telling my patients, you cannot go cold turkey. And they'll say, "Oh, I've done it before. It was fine." Or my Uncle Bob did it once, and he was totally okay. But it's like playing Russian roulette. You never know when you're going to have severe outcomes. So that's what I did. I said I had enough, so I'm going to stop drinking. And of course, the next day, I felt like absolute shit. Pardon my French, but that's how I felt. The severe alcohol withdrawal is not something I wish on anyone. It is absolutely awful and terrifying. And so at that time, I called the ambulance to get the appropriate care. They came and picked me up, and I went to the emerge, and I was very forthright with my history. We, as clinicians, we're always looking at that history of why someone's coming in. And even in that state, I could tell them I'm drinking like a lot right now, because I knew that would be important information. That was a very poor experience for me. I was treated with tramadol, so they gave me an opioid, and I felt great for like a good hour or two, because maybe a bit of euphoria from the opioid, I'm not sure, but it sort of staved off the withdrawal for an hour or two until it didn't. And so that's the beginning of my story, and then we'll get back to the kind of meat and potatoes of the presentation. I think I can check. All right, so we're going to return to the end of the story as we get through, and you'll find out kind of the outcome of what happened and how I'm here on this stage today. So why focus on treating withdrawal? Patients experiencing withdrawal symptoms between drinks will have difficulty reducing their symptoms. Naltrexone and acamprosate were not designed to manage acute withdrawal. And treating alcohol withdrawal can be, of course, an emergency intervention. We want to prevent those. We want to prevent and treat any seizures. And often it can be a planned therapeutic intervention for motivated patients. It may be required to prior admission for a lot of our residential treatments, and it can lead to improved AUD outcomes in collaboration with anti-craving medication. Untreated or ineffective withdrawal management can lead to return to drinking, like in my case. Reluctance to engage. So why do people not engage in these services? There's a lot of shame associated often with this substance use. There's a lot of guilt as well. Oftentimes there's comorbid anxiety and depression issues at hand. Some people naturally try and cut back their alcohol consumption, and they get those withdrawal symptoms like insomnia, anxiety, rebound, depression, etc. And so how do you treat that? I'm going to have some more alcohol. That was the case for me in many situations. Feeling they can do it on their own, that's what I thought. Okay, I could just stop. I've had enough of my substance use, so I thought you could just stop. You certainly cannot do that. Stigma. This is a deep one. I had some pretty poor experiences at the emergency department, and also thought I didn't need medical care when going cold turkey. This is very broad. It's different, of course, for each individual. These are just some key points. So how to help people engage? We want to be working collaboratively with patients and really assess what goals they have in mind. We want to discuss going cold turkey or tapering. If you look at one of our wonderful Medify handouts, we talked about getting a turkey, and we got a turkey on there. Images can be powerful, and that one might stick with people. We want to assess their readiness. Whenever I'm training nurses, nurse practitioners, residents, primary care providers, whoever, through my RAM clinic, I put a huge emphasis on being able to establish that rapport with patients. When they're comfortable with you, you can really get to the nitty gritty of coming up with a plan and seeing where they want to go. We want to discuss management of underlying trauma, comorbid conditions, and we really want to look at their home. We want to see if there's family support, pressure at work, relationship breakdowns, divorces, stuff like that, to see what might be kind of urging on the substance use. The other thing is we want to offer a menu of options. So again, with client-centered care, you want that patient to be kind of guiding the process with you. Of course, there's situations where I say you cannot go cold turkey. This is very dangerous. Like, we need supports in place, but we want to offer a menu of options. Are there withdrawal support teams? And I'll touch on ours later in the presentation. Are there any safety risks at hand with the individual, and what are the preferences? We want to discuss adherence and explain how and why medications work. And again, just on a quick personal note, I was prescribed baclofen, which is certainly an off-label use for alcohol use disorder, used 10, 20 years ago, not so much now, and some people still do, but I was prescribed baclofen on a high dose for a while. I found it quite helpful, and I was prescribed naltrexone as well. This is a piece I often try and implore to other clinicians, is that medication adherence piece. I never took the naltrexone, ever. I tried it once or twice, and oftentimes there's familial pressure, there's job pressure to go to a clinic and pick up a script and say, hey, look, I'm doing something. But to me, it's like, it's like I could eat a plain overcooked burger with no meat, or a beautiful Big Mac. I like Big Macs. And I'd always go for the delicious Big Mac without the naltrexone. And sometimes folks will tell me there's symptoms with the naltrexone, it's just not working. And I don't disvalue that. But sometimes when you have that strong therapeutic rapport, you might be able to find out that a lot of individuals are just not taking it. Let's get Vivitrol. I think that would be great to have someday, the injectable form. But I get tangential. So back to the subject. And then I think I pass it off to Katie here.
I'm not that tall. Thanks, Adam. So we're going to get into some of the nitty gritty of actually what withdrawal is and the beginnings of treatment. So random poll for the audience. I've done this a couple times today, so I'm curious about what it is now. But you personally or your clinic, your organization, wherever you work, do you guys treat alcohol withdrawal? Okay, mostly. That's great. That's fantastic to see. Do you offer home-based treatment of alcohol withdrawal? Still a huge chunk, which is good. Does anyone offer in-office treatment? Some, not as many. How about short stay units or a day detox? Amazing. There are some. Cool. Local withdrawal management services. A lot of people have those too. Fantastic. Okay, cool. So just kind of wanted to see what the lay of the land was in terms of what is accessible or not accessible for people around. Those are all options for withdrawal management that we're going to talk about in terms of what's appropriate for location and what treatments are appropriate for those locations. If you were at one of our last presentations, we highlighted the RAM clinic quality targets. So this is something that Medify has produced to help guide certain addiction clinics, rapid access addiction medicine clinics, to kind of know what the baseline of treatment should be. And one of them is definitely care addresses the spectrum of substance use with a direct quote of whenever possible and appropriate, RAM clinicians should provide support for acute alcohol withdrawal. So I'm really happy to see that so many people already are. And if you're not, hopefully we could get you there or your clinics there. Physiology can sometimes be boring, but I do think it's really, maybe I'm a nerd, but I think it's exciting and interesting when it comes to addictions and specifically for alcohol withdrawal, for not only understanding it yourself and why you're choosing those medications, but also sometimes to explain to the patients what's going on with them. So I've used this often if you've heard me speak before. It's just a nice diagram to kind of understand what's happening. Our bodies are always looking for equilibrium. That's something we learn very early on in school, is that we want a balance between everything, a nice state of equilibrium. Here we're going to be talking about mostly GABA as an inhibitory factor and glutamate as an excitatory factor. In general, those should be in equilibrium for most of us. If someone were then to consume heavy amounts of alcohol and they were to do that on an ongoing basis, so they have prolonged use, alcohol is going to add to that inhibitory effect. So it's adding to where that GABA already was. Our bodies are brilliant, and in trying to find a new equilibrium, they are going to increase glutamate or excitatory factors to try to balance that out. That is the reason that you can see people that drink so heavily and that drink for such a long period of time but seem to be functional. As part of Adam's story, I hope it's not spoiling later, he completed nursing school. So he was absolutely functioning, and probably you wouldn't have known unless you were talking to him directly about the level of consumption that he was at. Hope I didn't spoil anything, Adam. Beautiful. Thank you. If someone then, like Adam's part of the story already, decided to go cold turkey or suddenly cut out alcohol, that huge impact of the inhibitory factor that was there is now gone. But glutamate doesn't go away as quickly. In fact, if you're looking at the timeline of alcohol withdrawal, acute withdrawal typically lasting about 3 to 7 days, that's how long it would typically take for your glutamate levels to kind of balance out to find a new equilibrium. So you can see you have lots of glutamate, lots of excitatory factor. We're going to talk about what that means in terms of hyperexcited state for your body in acute alcohol withdrawal. I think that's in the next slide. To balance that out, how do people prevent complications from happening from acute withdrawal or just feel better when they're in acute withdrawal? You have to add something that's not going to be excitatory, something on that inhibitory side. I highlight here benzodiazepines. We're going to speak about those specifically, but also other options that modulate both GABA and glutamate. Clinical features of alcohol withdrawal. I know you all know this because you just said you treat it, which is fantastic. But just to go over it really quickly then, withdrawal is uncommon in people that aren't drinking at least, we kind of quote, around 5 to 6 standard drinks per day. And it really does need to be kind of daily drinking for about 1 to maybe even 2 weeks for you to experience real withdrawal symptoms. Even after that, not everyone will experience withdrawal, or if they do, it may be mild. But as we know, especially if you work in the substance-based area, people can experience moderate and severe withdrawal symptoms. Those are really the people we're trying to target to make sure we're treating them and preventing those bad things from happening. Luckily, alcohol withdrawal is pretty darn predictable. The typical onset is about 6 to 12 hours, and it's pretty regular for that, which is nice. There are a couple outliers that we'll talk about in the next slides. There's also this thing called the kindling effect, which is maybe best explained by just reading this quote that I have on the screen. The term kindling refers to the phenomenon that people undergoing repeated cycles of intoxication followed by abstinence and withdrawal will experience increasingly severe withdrawal symptoms with each successive cycle that happens. So I am sure there are many clients flowing through your head that you have seen numerous times in your clinics or in your emergency departments or wherever it is that have tried this and have tried this and have tried this. And they may never have been a person with a seizure history or delirium tremens in the past, but the more that they go through this, if their drinking is unchanged or increasing likely, then they are going to be at increased risk of this occurring. Just something to keep in mind with those repeated cycles that are very common for people with alcohol use disorder. Luckily, acute withdrawal usually resolves, like I said, on its own within 2 to 3 days, kind of to a max of around 7 days. It could extend beyond that. These are the DSM-5 diagnostic criteria for diagnosing alcohol withdrawal. If you heard me speak this morning, the CWA is a scale that helps to monitor the severity of withdrawal. It doesn't actually diagnose this. You would actually need to go through these criteria if you really did want to diagnose it, which goes with a daily prolonged drinking that is suddenly decreased or suddenly stopped, having any of the symptoms that you're going to see on a CWA, honestly, and then like most DSM, it's going to say, and not otherwise able to be differentiated into a different category or diagnosis. I like this slide a lot for giving a quick overview of the timelines for withdrawal. So when I said there was some variation, it is pretty darn predictable, in the onset being about 6 to 12 hours. And if you ask your client, they really will tell you exactly when they're going to be feeling withdrawal from their last drink, if it's tomorrow morning, later tonight, or maybe in 2 days for some people. Minor or more mild withdrawal typically begins a little bit later, maybe closer to that 12-hour mark or even beyond that. It also tends to end a little bit earlier for those people that experience it. Someone that's going to experience a more moderate to severe withdrawal are going to start feeling it closer to that 6-hour mark, and those with real severe withdrawal or risks for complications can have those happen even earlier. Honestly, before you would even say that they're out of intoxication, these can occur as just their alcohol levels are decreasing. Seizures or alcohol withdrawal related seizures typically occur early on in the course of withdrawal and happen most often when someone is having extreme states of hyperactivity. So you've got all the autonomic symptoms going on, they're really unwell, and then you're going to have a seizure in those states. Typically between the first 6 hours to about the first 2 to 3 days, after which, if withdrawal has been managed well, we should be lowering our risks of that occurring. Seizures can happen in about, kind of estimating quotes here, of about 10 to 15% of those with severe withdrawal histories. So just as a heads up, they're not that common, but if you work specifically in this field, that's why you're seeing it more often, because it's 10 to 15% still. Delirium tremens is a later event in withdrawal, so it typically won't even present itself until 2 to 3 days into the withdrawal experience. This is when you're getting confusion, disorientation, along with that autonomic hyperactivity. And I do like to say that you can't say anything always, but it could be preventable. If you are catching and treating your withdrawal symptoms appropriately and early, we don't need to end up at that period of time and going into that state. This is the CWA very quickly because it's pretty much the same as what I went over this morning. So the CWA is just to monitor alcohol withdrawal severity. A couple tips if you haven't heard them already. You do actually have to wake a sleeping client if you are an inpatient clinic to do the withdrawal assessment and make sure you're treating appropriately. Watch the patient. You don't have to just listen to what they tell you in terms of scoring. Watch what they're doing and how they're interacting with you and behaving to guide your scoring. The tremor, it's very specific for acute alcohol withdrawal. So for just all alcohol withdrawal, it's postural and intention. So that's going to be with gravity and with an action typically. So you could have them take a drink of water. You can have them hold a piece of paper, whatever you wanted to do. And it's not going to diminish. This tremor will stay the same no matter how long you have them hold their hand there. For tactile, auditory, and visual disturbances or hallucinations, I'm glad that I wrote disturbances, actually. Good job, me. Because it really can just be disturbances. You don't have to have someone that has just florid hallucinations where they're seeing things or they're hearing things. You do want to be assessing if they're also just feeling like the lights are bothering them or that sounds are bothering or they're feeling itching on their skin. Those are also things that you would score on the CWA. And the frequency with which you're doing the symptom triggered, how often you're doing the CWA really does matter. Typically, we would say you want to be doing this scoring at least every hour and trying not to delay it, which is easy to delay doing your CWA if you're working in any kind of busy clinic. I pointed it out this morning, but I am very excited about this, so I'll say it again. This is an e-learning module that is free and publicly accessible through CAMH. It goes specifically through alcohol withdrawal, how to diagnose it, how to assess it. It goes a little bit into treatment, but pretty much stops there, and it comes with a certificate of completion. So if you are at an organization that is struggling in terms of getting a good inter-rater reliability for the CWA, just having everyone on the same page and consistently completing it, offering this is a great way to go. Anyone, I want to say across Canada, but I'm sure it could go beyond Canada, is welcome to utilize this. Basic principles of alcohol withdrawal management are to treat early and to treat aggressively. And if you do both of those things appropriately, then really we should be able to minimize the length of time that someone is experiencing withdrawal symptoms and prevent complications like seizures, delirium tremens, and hospital admissions. So complications of alcohol withdrawal then really occur when someone is late to treatment, which can be a system fault that we haven't stepped up and caught the patient early enough. And of course, we know that it also can be a patient presentation that they show up in fluid withdrawal and you're playing catch up when they get there. It can be because of undertreatment. For some reason, you've chosen lorazepam instead of diazepam, or you've chosen 0.5 milligrams instead of 2 to 4 milligrams, and you've repeated that cycle thinking it's going to work, but it just hasn't been enough treatment for that client. And I have inappropriate treatment with an asterisk just to say that, of course, every client is going to be a little bit different, and you want to make sure that you have chosen the right setting and the right treatment for that specific person. And we're going to talk about that more. Okay, this is a very quick overview for the medications for alcohol use and for withdrawal. And we're going to talk about the treatment gap that exists. I would welcome, because it's the end of the day, you all are here, good job you. Afterwards for the question and answer, it'd be fantastic to hear what other treatment options you offer in your clinics and the dosing and how you use them, what you think about them. But in general, when we're talking about treating alcohol withdrawal, as I've said, thinking about the physiology, we're really looking for medications that are going to modulate GABA or NMDA, which is the glutamate. Those medications include benzodiazepines, absolutely, but it also includes non-benzodiazepine medications, and there are many of those non-benzo meds that are shown to equally decrease CWA scores to a benzo. But we do pretty confidently know from repeated studies that benzodiazepines are the treatment that confidently prevent complications like seizures and delirium tremens from happening. So if you have anyone that is going to be at a moderate to high risk of those occurring, that's why you would see people reaching for benzodiazepines possibly more often than you see other medications. But we also have, very important to treat alcohol withdrawal, very important to treat alcohol use disorder and cravings. Unfortunately, this is where that treatment gap exists. Benzodiazepines are not an anti-craving medication. And most of us would say, because they do have risks of respiratory depression, they do have risks of toxicity, they do have risks of misuse and aversion, most of us would try to minimize the course that someone is on for a benzodiazepine for any reason, really. Anti-craving medications, on label anyways, thinking of naltrexone and acamprosate, they don't treat acute alcohol withdrawal. So this is the reason that people are really curious, and the studies continue to be published, hopefully more, for the non-benzodiazepine treatments that can treat acute alcohol withdrawal, but also could be maintained as an anti-craving medication longer term. Emphasis again, before it's pointed out by everyone, these are not for your severe cases where you're expecting seizures or delirium tremens. So there is a large component of you have to be sure that you're appropriately assessing where this client can go. But some of these, we're going to talk about gabapentin a little bit further. Some of these would include topiramate, which can decrease heavy drinking and return to drinking days. Typically starting, the titration can be a little bit difficult and can have some interesting side effects, starting around 25 milligrams, increasing to 100 milligrams twice a day sort of idea. Carbamazepine is something that a lot of people can use. It does very effectively treat acute alcohol withdrawal for mild and moderate considerations, and it can be continued. It does decrease heavy drinking days and return to drinking. A lot of patients find it very beneficial. It has a large list of interactions in terms of other medications, so you would want to know the medication well if you're going to be using it. And that could be used something along the lines of a diazepam taper, where you could do about 200 milligrams 4 times a day and kind of taper down from there. Pregabalin, I'm going to lump into my gabapentin talk in just a minute. And valproic acid, while there is research on it, I can't say that I've ever found that it has as much benefit in terms of the literature that's there right now. And baclofen and many others, as Adam had kind of pointed out before. I'm actually going to come back to that one in a second. So to stay on the track that I was on for non-benzodiazepines, the CRISM guidelines do recommend gabapentin for the management of patients that are at lower risk for complications. So they haven't had a seizure before, they haven't been admitted to the hospital, they don't report having delirium tremens in their past. It appears to be as effective as benzodiazepines in reducing the severity of alcohol withdrawal symptoms in the outpatient treatment of mild to maybe moderate alcohol withdrawal. Compared with benzodiazepine treatment, use of anticonvulsants like gabapentin alone increase the odds of requiring rescue medications. Again, I would say if you're not making sure that the patient's treated in the right location and with the right treatment up front. The mechanism, gabapentin increases the GABAergic tone and decreases the glutaminergic tone in the brain, which is going to find that new equilibrium balance that we were talking about. Benefits of using gabapentin, it could be less concerning with concurrent use of other CNS depressants, of course, return to alcohol, for instance, or combination with benzodiazepines. Less risk for diversion, potentially, depending on your community. I know some communities have heavy diversion of gabapentin, and it can be used as a second-line or off-label agent for ongoing anti-craving purposes in showing that it does decrease return to drinking and heavy drinking days effectively for some people. It does have its own side effects, of course. Some of the more common ones would be drowsiness, slurred speech, and ataxia. I would say that they're not as common, but some people get them. They will tell you pretty quickly if they get them, and you tell those clients to stop. The rest of the clients will typically have a tolerance and be able to tolerate this medication really well. We'll talk about doses in a second. There are some renal precautions to be aware of where you would typically use a lower dose. And in general, you would say that you want higher doses than maybe some people are expecting for use, typically at least around 1,200 milligrams per day for acute withdrawal purposes, if not higher. These are just some samples of gabapentin protocols if you are going to treat for acute withdrawal. So for those people that can't see and that are kind of leaning in from the back, for someone that does have a CWA over 10, you may consider starting gabapentin at 300 milligrams 3 times a day, plus another 300 1 or 2 times a day as needed on top of that, plus 300 to 600 milligrams before bed as needed. Because of its potential improved safety profile compared to benzodiazepines, you can feel maybe more comfortable giving these doses for the patient to take at home and the instructions to take as they see fit within these parameters, so they can have a lot more flexibility in terms of dosing themselves. Going back then to benzodiazepines, which I did highlight are the medication of choice for someone that's in the more moderate to severe, and definitely those that have a history of complications for alcohol withdrawal, or you feel are leaning that way. You generally want to be choosing a benzodiazepine that is longer lasting. Longer-lasting benzodiazepines will prevent the risk of rebound symptoms because they're going to just stay in that patient's system. I chose diazepam for this slide. You can choose whatever long-lasting benzo that you want. Diazepam may be preferred because it's metabolized to active metabolites, which is going to increase its duration of action, potentially up to 5 days after a dose. I really like to let patients know that even after they've stopped taking the medication, it's continuing to work in their system even beyond that. It's not that we just cut them off. Once acute withdrawal is resolved, prolonged action of diazepam prevents that rebound. Of course, shorter acting benzos need to be used for some patients that are at higher risk of toxicity. For instance, lorazepam. You would want to be considering that in a client that might be elderly or more the frail elderly, I would say. Patients with a history of cirrhosis with liver dysfunction in combination with it. I would say severe respiratory impairment is when you would want to consider this. And those that are on high doses of opioids, obviously that's subjective and up to interpretation for the client's other factors. I think I will pause there. We can continue the conversation about it afterwards, and I'll pass it to Jennifer.
Okay, so we already talked about what is withdrawal, why are we treating it, what are the medications, and now we're really thinking about where should withdrawal be managed. And, this is a Medify talk, so we're thinking about our RAM friends, but obviously not everyone is working in a RAM setting. And we're here at a national meeting, so I thought that we should reference the Canadian National Guidelines on Managing High-Risk Drinking and Alcohol Use Disorder, which my sort of disclosure I find a little bit problematic. So, but I think it's really important that we look at them, that we know what they say, and that we think about how we're going to apply them overall. So this is the CRISM guideline that was issued in the October 2023. There's a big long document on the CRISM website. There's a shorter version in CMAJ. The first recommendation regarding withdrawal is that the PAWS, the Prediction of Alcohol Withdrawal Severity Scale, be used to assess the risk of severe alcohol withdrawal. And I think probably everyone would agree that having some kind of objective tool to assess the likelihood of severe withdrawal would be a really good thing in terms of trying to think about where you're going to guide someone for this planned withdrawal journey. The next recommendation is that for patients with a PAWS of less than 4, or those at low risk of severe complications, those patients should be offered withdrawal management in an outpatient setting and typically with non-benzodiazepines, a list of medications that includes gabapentin, carbamazepine, or clonidine. We're not going to spend a lot of time talking about that, but I would have some, questions about why recommend carbamazepine and certain clonidine as sort of first-line non-benzo options. And then the final recommendation that patients who have a PAWS of equal to or greater than 4, which according to the guideline puts them at high risk of severe complications of withdrawal, be offered an inpatient admission for management. Whoops, I'm going the wrong way. Sorry about that. Okay, so we've already talked about what is severe withdrawal, seizures, delirium, the likelihood that if someone has had severe withdrawal previously that they're going to have it again, and then other kinds of conditions that could increase the challenges around managing someone on an outpatient basis, like withdrawal from other substances at the same time. So I don't know if everyone actually knows what's in the PAWS. It's talked about a lot these days, and I'm sorry that you can't see. I'm moving my way over here because I just wanted to be able to read out the questions for those who aren't familiar with them and talk a little bit about, what is the PAWS overall. So question 1, have you been recently intoxicated or drunk, i.e. within the last 30 days? 1 point, one for each of these 10 questions, okay? So maximum score of 10. Have you ever undergone alcohol use disorder rehabilitation treatment? So that could be inpatient, outpatient, including attending AA. Have you ever experienced any previous episodes of withdrawal? Have you ever experienced blackouts? Ever experienced seizures? Ever experienced DTs? Combined alcohol with other downers in the last 90 days? Combined alcohol with any other substance of abuse during the last 90 days? And then 2 last questions that have to do really with sort of signs or objective measurements. Was the patient's blood alcohol level at presentation equal to or greater than 200? And then is there evidence of increased autonomic activity? So the first challenge here is that obviously most people don't have access to measuring blood alcohol level acutely. There are 2 alternatives to using this. So the first is to use a portable breathalyzer and see if it's equivalent to that greater than 200 measurement. Or just reframe it and ask the question, have you consumed any alcohol in the past 24 hours? So I think, sort of a first thing to realize is that as soon as we start modifying the elements of the PAWS, then we're affecting the sort of integrity of the tool in terms of how it was developed for sensitivity and specificity. The second thing is that it's identified as a score of equal to or greater than 4, identifying the risk of high-risk withdrawal. And I would argue that any patient that we are seeing to plan withdrawal management is going to be a 4 before we ask anything else, right? They've come to us because they've been drinking in the last 30 days. Almost certainly they've been drinking in the last 24 hours. They've been engaged with treatment, likely AA, and they've already had some withdrawal symptoms. So that puts everybody into the category where theoretically we should be offering them inpatient admission. And that's just not practical, right? We all know that there aren't beds for everybody who's looking for withdrawal. The big a big issue is that the pause wasn't developed to help identify where people should be treated. The pause was developed to be implemented in an inpatient general medical unit setting to determine who should be offered treatment to prevent or treat withdrawal before progressing to severe withdrawal. So this was in patients admitted for other general medical conditions, right? It could be some kind of infectious presentation. You can imagine all different kinds of things, right? Congestive heart failure, cholecystitis. That was the setting in which it was recognized that alcohol withdrawal was really being undertreated, and that recognizing those who could benefit from early treatment would be beneficial. So that's a great place to use the pause. I would argue that in our situation, what we really need to do is at least acknowledge that we know that the pause is a tool that has been identified, and then think about whether we want to use it or whether we want to use our clinical judgment based on looking at the person's history, their circumstances, their needs, preferences, and our options. So as I've already said, I find it problematic because there is this lack of access to being able to really implement these recommendations in terms of inpatient beds and even withdrawal management setting beds. And in WMS, there may or may not be access to people who can prescribe medication. It's challenging. Again, we're sort of setting up this expectation for people who don't necessarily have stable housing that they need to be admitted. And then, of course, we have other challenges around who has the skills to manage this. So I thought in terms of thinking about who can be managed in the community, I would just, again, think about who actually should be managed in an inpatient setting. When is that really important? And then kind of the other people. What's left are the people that we can think about supporting somewhere else, whether that is in our sort of, day TDOC's office unit, withdrawal management, or home. So obviously those severe withdrawal symptoms, people who have that history, as Katie said, we know it repeats. We know with kindling it gets even worse. People who've required admission previously, especially if they've required an ICU admission. People who are acutely unstable in terms of either medical conditions or mental health conditions that could destabilize with withdrawal or could make it difficult for them to process instructions, take their medication accordingly. And then, as we've said, those who are going through withdrawal from multiple substances or who could experience more severe complications. So women in pregnancy where the withdrawal could be a risk for preterm labor, and we want to be monitoring really closely. So kind of everyone else, those who don't have a requirement for inpatient admission, who can take oral meds, who can understand instructions, where they can follow up for at least the first few days. And safe housing doesn't mean their owned home, right? Someplace safe that they can stay. And someone, ideally a person who can support them. And I think this is where we sometimes need to be creative, right? It does not have to be a family member. Could we use some kind of community support person, a pharmacist, or one of our staff members? So thinking about those things, right? If you are in your office or, again, this is the Medify talk, in your RAM, and trying to think how you can support someone, how does that map onto what your resources are, right? Who is the person that you're seeing? Are you planning an admission, or are they actually in withdrawal at this moment and you need to be acting quickly? What kind of space do you have? Do you have a room with a bed or a chair? And if you even did, how many hours can you be there? Can you bring someone in early? Do you have staff who can support and monitor that person? Do you keep medication in your clinic? If not, how would you access it? And what are the partnerships so that if you're making this plan and it's not going as intended, how are you going to be able to support that person in terms of transitioning them? Adam.
Fix this guy. Test the clicker. Oh, cool. All right. I had to take the jacket off. I usually just wear those for weddings and other things. I'm usually in scrubs. So home withdrawal management. So we certainly have some criteria that we have to go over. I'm going to be talking about the sort of practical components of our clinical program. Again, I work in a RAM clinic and also a community withdrawal support program. So there are some criteria. Of course, this individual has to be motivated to quit for a time. And sometimes for some people, even just reducing their alcohol for a couple months at a time, sometimes it's a couple years, can be beneficial. Kind of a nice fresh reset, even if they return to drinking. Stable living environment. At our clinic, our usual criteria is that someone has to be there to support the withdrawal situation. They help with handing out medications and monitoring. Again, this is sort of repeat, but no high risk or unstable comorbid conditions, ability to follow instructions, seek help if needed, follow up. Big pieces for us, again, are no history of seizures. We do not do outpatient withdrawal management if they have a history of seizures. Again, as Katie touched on, there's the kindling effect. So any of those high-risk folks, we're going to be sending them down to our awesome withdrawal management service in town or the emergency department. This is our home treatment protocol. So nice little map there that we've had for a while. And we've got a rigid, flexible, and front-loading dose. Wonder, does this thing have a laser? Oh, wow. Okay, so we've got rigid, flexible, and front-loading. Just from a practical perspective, what our nurses do when I'm working with a primary care provider or someone out in the community, more often than not, we're going to be going for the rigid approach. And this is often because our primary care providers are more comfortable with this, and it's easier for our patients to follow. Sometimes we're flexible or doing front loading, but more often than not, we're going to be doing the rigid approach. Of course, we don't want clients to be mixing the diazepam and the alcohol. That's a huge teaching that we say you cannot mix these. It's very dangerous. Of course, we don't want to put both of those together. And we assess the patient as well. We let them know when they've got to go to the emergency department or seek out more help, and that's usually our more severe CWA symptoms that we go over. I often tell my folks to have a last hurrah, just have a day of drinking to their normal amount, and then we usually start the protocol the next morning. So we have our Community Withdrawal Support Program, or CWSP. And what our team provides is frequent follow-up. So especially if they're doing a diazepam taper at home, we'll be doing daily check-ins where one of our RNs will be doing CWA and checking in. And we also provide immediate support at time of intake. We do a bit of brief counseling. We do have wonderful peer support and counseling services at our organization at the London RAM Clinic. And we also provide education, relapse prevention, and we love working hand in hand with our primary care providers. A lot of our work is like Medify and all the wonderful work you guys do, and that's education. So that's going out and having fun chats, all things addiction medicine. This is our team. So I get to use the laser again. Sweet. We got 3 full-time RNs, 1 part-time RN, a full-time NP, and physician for consult. So those are a few of us. Some of them are missing, and things have changed. And then those are my 2 dogs and my cat. So we've got Ro, Mo, and Bo. This is our team as well. This is our RAM team. And if you look closely, this was just a week or 2 ago, and I'm going all over the place, but it's fun to spice things up. But they decided to dress up as me for Halloween. And you can notice they got the neck tattoos right over here. We've got some wonderful mustaches, a little bit of a 5 o'clock shadow there. A sleeve here from one of our nurse practitioners. Everyone also has fisherman friends. I have fisherman friends over there. As you can see, I love fisherman friends. And also my dear friend, Dr. Adam Rocker, who's in the back there, he's got a little hat on that says McGinnis Meats. Anyways, it was hilarious. And I've got one more picture. Okay, back to the presentation. Withdrawal management services. This is not me, I don't think.
That was a good break. Good laugh. Thanks, Adam. So withdrawal management services, just talking about another location that you can try to send your patients to if you have it available. If they're not appropriate for home, they don't have a home or a safe space to go to, and if it's accessible. A lot of clients will say that they can't do it on their own, so this would be a good option for those clients, or that they just need to remove themselves from the environment that they're in. A lot of the times their social setting will be surrounded by family or friends that also consume alcohol or other substances, and withdrawing, if they're not all doing it together, can be very difficult to be the only person going through this. So it could just remove them for a little while. Like Adam said, sometimes you just need a break for a little bit to kind of reset and figure out what your goals are. So this could be a good option. If you don't have a support person, and unfortunately a lot of our clients will not be able to identify anyone in their life that could be that support person for them, this would be another good option. The staff could kind of act as that support person for them. They would benefit from those eyes on them. They have a little bit of monitoring, so if they are not able to say themselves when they should or shouldn't call 911 or go to the hospital, someone else can do that. Or, of course, also, unfortunately, like many of our clients, if they can't manage their own medications, someone else can do it for them. They will bring them to them, or they can go and get them at the nursing room, which is fantastic. Withdrawal management services, I'm going to talk about Ontario. I apologize if you're elsewhere, but across Ontario, they're varied. The funding has come in bits and pieces over many decades, which means that every withdrawal management service is staffed a little bit differently and practices a little bit differently, which can make it very difficult for anyone that's not in those facilities to know what the heck is going on in there. So you really will need to make your own connections with your local withdrawal management service. Become friends with them if you can, so that you can refer clients in, they can refer clients back, and you can know exactly what happens for how to get a client in, get them a bed fast when you need it, and what kind of supports they do or don't need from you from the outpatient prescriber. I would say most of the withdrawal management services, I've been spoiled to work at a number of them now in Ontario, but most of them have a nurse practitioner at least now, if not a couple that are providing coverage in patchwork ways across the week. So there should be at least some prescribing that's available in Ontario for them. For RNs and RPN coverage, it's very varied. Unfortunately, some withdrawal managements have them, some have them 24/7, some don't have them at all, and they will have more support workers or addiction support staff that would be there to more monitor, provide medications for clients to self-administer. So you really do have to know more about your local service. If you're looking to know more, Connects Ontario is a fantastic option for Ontario. I apologize for everyone else, and the link is there. The staff on Connects Ontario know all about the withdrawal management services and can help the client to get to the one that they need to go to and kind of learn more about the eligibility. Medications are another varied thing, unfortunately. I wish this was more regulated across Ontario or across all withdrawal managements. Some will have the ability to have stock medication on hand. So if you do send someone in and you don't know if they have stock medication on hand, don't send them in withdrawal. Make sure that they're showing up ready to have an intake. That can take some waiting, that can take some time. There can be clothing and belonging checks, and then getting into a room and settling, and then maybe they'll be provided with medication, or maybe they'll be connected to a prescriber who's then going to order medications to be delivered. If they go in withdrawal, they're really not going to enjoy any of that process. It's going to make no one's life easier. So if you're not absolutely sure that your local withdrawal management has meds in stock ready to give right away, then make sure you prepare the client. I don't use the same words, but to Adam's comment of have your last hurrah, make sure your last drink is a couple hours before you go in at the latest. Partnerships, I can't say enough about them, how important they are in terms of making the communications between an emergency department and any kind of addictions or primary care clinic and the withdrawal management are so important. There are so many clients that don't need to live in the emergency department and don't need to be admitted, but do need to start there. But hopefully they could then transfer into the withdrawal management, and hopefully they don't need to stay there if there's a lot of community supports, that they can kind of transition through these services more smoothly if these relationships were already predetermined. In terms of then, if the staffing is questionable and the medications are questionable, then you really have to find out what's going to be possible in terms of dosing for the withdrawal management that you're in. hopefully they'll be able to provide benzodiazepines or other acute withdrawal management treatments, at least on a fixed dose regimen as someone would get them at home, but with the eyes on and with the monitoring of that medication. So that is one example that you could use. This is kind of a sample of an order set that I would use when I'm covering our local withdrawal management service, where I often do transfer from using front loading of medications to make sure the clients get the early treatment, the aggressive treatment that they need when they enter into withdrawal. The staff there have all been trained to know exactly what that means, when to send to the emergency department and when to hold the medication. So I feel confident working with them. After those loading doses are in, we usually transfer over to a fixed dose schedule with a little bit of flexibility with PRNs, which is nice, only because a lot of withdrawals will struggle with staffing, and CWA and symptom triggered is absolutely the gold standard, but it's just not possible everywhere. And I'm sure everybody knows that as I'm getting nods across the crowd. So this can work really well for a lot of people. And when you switch from loading dosing to a fixed or flexible dosing schedule, you could continue benzos to benzos, but you also have the opportunity then, of course, to go from benzos to a gabapentin or to another option that you may want the patient to continue outpatient as well. Jennifer.
So I'm going to talk about a program we have at Women's, and I know how lucky I am to have it. But I think, I want to share the work that we're doing and also think about whether it could be modified in other kinds of settings. So Women's College, you may or may not know, is an ambulatory care hospital. And what that means is that 95% of our services are all provided as an outpatient, on an outpatient clinic basis. But we have this short stay general internal medicine unit that we call the double AACU, and it functions as a general internal medicine unit mostly for offloading patients from emergency departments who need short-term management for acute hypertension, congestive heart failure, AFib, sometimes for workups and different kinds of infusions. By agreement with the Ministry of Health, we are not allowed to admit people for more than 24 hours and a minute. So our admissions are technically up to 23 hours. There's a physician on site, a general internist, and a couple of medical nurses at night, maybe 3 or 4 during the day. The hospital does not have any ICU capacity. There's no anesthesia on site. So we have the privilege of being able to admit people for a one-night stay, as long as they're not people who we think have a high risk of progressing. So people, for example, who have had seizures while being medicated, we wouldn't admit to our unit, but if they've had seizures when they weren't being medicated for withdrawal, they would still be candidates. So we can pre-plan this admission. Similarly, we advise people to have their drink the night before their admission, to come in early. Whoops. Okay, imagine that's rotated. I don't know how to do that now, or why that happened. But that's a welcome door. It looks like a little quiet hospital unit with a bed and a monitor and a washroom. And we have a therapy plan. So we've sort of created these orders. This is just the paper version, but they're in Epic. And so whoever is planning to admit the person can fill those out in advance, again, based on, what we anticipate their needs to be. We use a symptom triggered, so a CWA protocol typically. With diazepam or lorazepam, with the option of doing loading doses for people who've had more severe withdrawal in the past, and then moving on to a CWA-based protocol once they've completed their loading doses. Those doses of thiamine are not correct on there because we would aim for 300 milligrams. And so, again, these are, not specially trained nurses, but they've learned to do the CWA. We've done some extra education around CWA monitoring overall, including things like waking people up overnight. And this is a review of patients admitted over about a 2-year period between 2020 and 2022. So again, these are patients who've already been engaged with our service over time. The mean age was about 45. The mean number of standard drinks per day for people who were admitted was about 12, with a range of 7 to 17. So not like 40, that's fair. But still some people with some fairly high intake. A lot of those patients had obviously been working with that previously, right? So, this is the idea of people who've already been on naltrexone, maybe plus or minus gabapentin. We're working on mental health. They're getting some psychosocial supports. They may even have tried home withdrawal, but they're still struggling to reduce their alcohol intake in a meaningful way, and looking for some extra help. So of those admitted, the range of CWA scores was from 13 to 24, so pretty significant. And the range of diazepam that people received was up from 33 and up to about 120 milligrams maximum. And everyone was out of withdrawal by the time we discharged them the next day. Of people who came back in a month, over 90% had significantly decreased their alcohol use or were abstaining. And to the right is people who came for a 3-month follow-up appointment. And again, the vast majority had significantly decreased their use or were abstaining. And then we also looked at domains of well-being. So psychological well-being, being at work, engaged with family, involved in some kind of counseling or psychotherapeutic activity. So big improvements. I think there is something that's really, really important about being able to help people who are struggling to find that way of being accessing safe support for withdrawal. It doesn't have to be in a short stay unit. Obviously, we've talked about a whole bunch of options, but the benefits to completing withdrawal are really significant. So, when I think about who we can bring in, and again, recognizing that it's a privilege, it makes me really wonder, do we need this kind of admission? I mean, first of all, a short stay admission is obviously much less resource intensive than an admission to an inpatient unit, right? And we've demonstrated everyone had to leave in less than 24 hours. So the vast majority of people, unless they have super severe withdrawal, don't need multi-day admissions. But could they be managed, as it sounds like people are doing, and I'd love to hear more, in a day detox, right? Could we bring them in early, kind of front load them as Katie has suggested, then monitor, and then send them somewhere, whether that's home with support or whether it's to another setting afterwards. In our setting, if we were just doing this upstairs in the clinic unit, I know that some RAMs sort of stock medications. We don't, so that is an important thing to think about. We don't have the nursing staff to be able to do like the twice daily checks of controlled medications, but we do have a system for accessing benzodiazepines from the hospital pharmacy, or there's a retail pharmacy that's on the main floor. So all of those things are things to think about, and then really the plan for where people are going. I know you've heard many times, so anti-craving medications aren't treatment for withdrawal, and withdrawal medications aren't treatment for AUD, and so we really need both. We want to make sure, I think it's not uncommon that we forget to remind people to take thiamine. And in fact, taking a multi-B and folic acid is probably a good idea too because of long-term malnutrition. We really need to make sure that follow-up is planned, whether it's RAM, clinic, or elsewhere. When we're looking after our colleagues' patients, communicate with primary care what they're doing, both so they know what's going on with their patients, but also because they learn from our letters, right, about how we're managing and what they could include in their own practices. And then all of the other supports that we want to continue in terms of medical health and mental health. And then other things just to think about, right? What's the right setting for the elderly, for youth who obviously are binge drinkers, but really don't experience much in terms of severe withdrawal, and pregnancies, as we've already said, should be in a monitored setting. And I think these findings and what we've said is really kind of borne out by the literature. People actually like to be at home rather than being in another setting. It's more comfortable. They've got their things around them. For people who are trying to get some work done, they can kind of work through things. I think that's on the next slide, sorry. But community detoxification can really be appropriate, more cost effective, much easier to manage in terms of resources. But we need to be really mindful about who is appropriate for which setting. I know Katie and Adam both talked about sort of loading, fixed, and flexible. I think all of that is true as long as the instructions to the person are clear, right? So getting people to sort of try to score themselves and gauge how much medication to give themselves, I don't feel great about. Having said that, when possible, I have to acknowledge I like using benzodiazepines in the outpatient setting rather than gabapentin. I feel like I have a much better way of gauging the effect of a benzodiazepine on withdrawal than of gabapentin. And so, I know that the CRISM guidelines say use non-benzos, and we know all the reasons to do that, but I like starting with benzodiazepines and then transitioning. So thinking about how we can do this in a really timely way, and thinking about the importance of the relationship. And that is what's conveyed in the literature. The medications are useful, but that perception of support from the team is what seems to really make a big difference. And I think that's the perfect spot to hand back over to Adam to wrap us up. Oh, I stole your slide transition, sorry.
Why chicken? It's not because dinner is coming up and I'm not trying to get you hungry. Excuse me. Oh, sure. It's not because it's almost dinner time and I want to make you hungry. One of the really key points I learned in my public health training is the power of story and lived experience to direct change, and that's sort of why I'm telling my story today. I don't usually tell it, especially in a room full of fellow clinicians. There's still a lot of internal stigma within even my own journey. I've done it for ER nurses before, but I think it's important to tie all these pieces in together. And I'll just keep an eye on the time because I know we're going to be wrapping up shortly. But I'm gonna go back a little ways, and this is before my first hospital visit for suicidal ideation, and this is when I went and saw my primary care provider. And he was wonderful, person and provider. And this was before Medify, before RAM clinics, back in the old days. And what he told me was, Adam, you have to stop drinking. If it was only that easy, I think we'd all be out of work, right? Like if it was such a simple approach, we'd certainly be out of work. He also recommended AA, and for as a young guy, it just wasn't a good fit for me. It does work for some others. I'll get to the chicken. It'll make sense in a second. And so had that primary care appointment, and now going back to my emergency visit where I was treated with tramadol. And again, I felt wonderful when I got it. It seemed to sort of taper down my discomfort, and they sent me on my way. And it was helping until it didn't. And I did what, I don't know, I feel like a lot of young men might do, or whoever, and I called my mother because she's always a support in my journey. And I said, I'm not doing too well. She was aware of my drinking, and again, had some family history as well. So she drove down all the way from London to Sarnia, or I call it the Sarn Barn, which is about a 45-minute drive. And that was the worst drive home ever. I was in severe withdrawal. I still, on occasion, don't like highway driving because it brings me back to that feeling. And so drove back. I felt like I was a hair away from a seizure. Again, that impending sense of doom that we often discuss as a symptom, that feeling of I'm going to die, really was there. It's hard to describe how that feels. It's just not a nice feeling. And so we called our family health team. Of course, it was 8 or 9 at night. The doctor was not available to support. It's just an odd time. And so luckily there was a nurse practitioner attached to the family health team, and I saw her. I honestly don't recall the interaction too well. I was not doing well, but she prescribed the correct medication, diazepam, not tramadol. And this is why we do a lot of this work. It might seem like basic care, but it still isn't completely there. So I got the script. We raced over to Rexall, and I was pacing the pharmacy because I was so sick. And of course, I didn't have my health card. Like, yeah, I still do stuff. Like, I still misplace objects, but I did not have my health card, which can be a challenge if you're picking up a controlled narcotic. And this is just a shout out to our pharmacy team and our pharmacist friends, because the pharmacist could see how sick I was just pacing the halls of Rexall, and she gave me the medication without issue. I took that pill. I started to feel great. Like, I can't remember the timeline, but I started to feel a lot better. And this is where the chicken comes in. So I can use the little pointer. This is Swiss Chalet, and I absolutely love Swiss Chalet. The family pack is wonderful. So I took that diazepam pill, and we went to the drive-through, picked up some Swiss Chalet, and as Jennifer mentioned, kind of going through this at-home process of relaxing, doing work, stuff like that, I got Swiss Chalet, and I felt great. And that's the importance of treating alcohol withdrawal and any withdrawal in any setting. I went home, had my Swiss Chalet, and watched the Blue Jays. It was great. It was back in the Jose Bautista time. Or I think it was around then. So there's the chicken. And then currently my recovery. So I've been in recovery, I think 6 to 8 years. I don't really count the days or years. I appreciate some people enjoy that. It's not for me, but I've been in recovery 6 to 8 years. And I managed to pass nursing school, as Katie mentioned, drinking quite a bit. Finished that. My third and fourth year, I was not drinking, which probably helped my grades. And after that, I had a placement. I wanted to do pediatrics, and I had one pediatric rotation. I couldn't get a set of vitals on the little thing. It was like, just, okay, the pediatrics is not for me. I did a placement at the withdrawal management. It stuck to my heart. I felt for the people in that place. It's part of my story. And so after nursing, I went to the Dalalana School of Public Health, completed a graduate degree in community health and specializing in mental health and addictions. And this is during COVID, so I started the degree during COVID, which is a wild time, like halfway through public health. COVID happened, so I didn't get a convocation. This was me just on the street. And luckily, some stranger saw that I was taking pictures. It was cold that day. It was like 10 degrees. It's not appropriate attire. But that nice person said congrats or something like that. I've worked in addictions for 4 or 5 years now. I'm back to school, I think, as was mentioned, so I'm doing my nurse practitioner. I've got 1 more year to go. Big paper on Monday, so I'm going to head out after this. And where am I going with this? Basically, recovery is achievable, and I know a lot of people, we have folks that come and go, and you don't get to hear these good stories often, or not often enough, but there's many people out here like me, and just a warm thank you for all the work you do, and I think that's it. And I guess we got questions, but that's my story, and thanks for listening as I went all over the place.
I think the questions are probably all for you, Adam. But I'm going to go 1, 2, and then there was a 3. Sure. Yep.
outpatient withdrawal management as a day program and other kind of aspects of treatment connected to that. But am I kind of correct in that for your RAMs, it's more of a home-based withdrawal versus kind of a day withdrawal, but maybe there's some exceptions? And just to clarify that, and then I'm also curious, like it's been a big change in culture for us in Nova Scotia. There was a couple of teams doing outpatient withdrawal management, but largely forever we've only had inpatient withdrawal management. So it's a big culture change for clinicians and for patients and clients to be receiving withdrawal management in the community and not in an inpatient setting. And I was wondering if anyone had any kind of lessons learned or folks are if you're impacted by that at all, and you know, is there totally a client choice and selection of setting, or are you kind of mostly focusing on your kind of criteria and clinical judgment?
I mean, I can share a little bit about my experience at Women's. We've heard others. Katie works in the aspect of RAM that she works in is digital. So so doing sort of a supervised day detox is not an option. I know you do a lot of home withdrawal management. I'd be curious to hear from others, but I think the pandemic was a huge change for us, right? And there's no going back, as in so many ways. So I think that we really looked at developing criteria and models for supporting people at home during that time, including, you know, doing video visits to check in with them. And we really haven't looked back. So, you know, it struck me as we were talking about preparing this that I'm doing home withdrawal. I can talk about our short stay unit. I know we talk about day detox, but I'm actually almost not doing it at all. Unless someone came in acute withdrawal and I wanted to sort of keep them and monitor them and then send them home overall. So I think the idea of having an intermediate place, something between home and inpatient, is really critical because certainly not everyone has the supports or the environment to do it, and inpatient is obviously just inaccessible and not appropriate. And I think a lot could be done in a day, but a day is like how many hours, right? You know, so it can't just be a morning or an afternoon. Obviously, there has to be enough time to give someone a good dose of medication and monitor them. If you're doing a sort of loading dose, right? 3 hours, then they're likely to be a bit sleepy, then kind of reassess and plan. So a full day's worth is, you know, the way I would look at it, 8 hours. So, but I don't know if anyone who's doing day detox or office based in other settings wants to kind of share their processes. Yeah. That's awesome. Yep. Mm-hmm. Please go ahead.
So I work again with the Community Withdrawal Support Program. Before that, it was telewithdrawal, and our program's been in place since I think it was around 2015, 2017. So we've been in the game for a while, and so facilitating home withdrawal management is just a wonderful option for folks. They can eat Swiss chalet and watch the Blue Jays. Again, there's criteria, primarily seizures, support people at home, but we've helped set up some of these programs in Northern Ontario and other areas. So if you ever are looking for support, I'm sure Medify and myself would be happy to help.
And that limits, sorry, Adam's not promoting it enough. It's really a fantastic program that he has that so many people have replicated in terms of the community withdrawal support, because it's one prescriber required one time, or they just communicate with primary care or other prescribers, and it's a team of nurses, RPNs, maybe an NP, and other support team that really take over the care and check in with that client and make sure they're safe at home, which just helps to utilize the medical system, I think, appropriately. It doesn't have to be prescriber heavy or emergency department heavy at all. So he's downplaying it, but it's a pretty darn brilliant program that can be implemented in tons of different regions. The clients love it, obviously.
Yep. Vincent.
So I work down the street from you in Toronto, and some of you something. So the question I have is, around the comfort level using benzodiazepines if there's a co-occurring opioid use disorder and methadone prescription. Is there a level of comfort with that, or yeah, what's your approach?
It's an interesting question because I'm trying to think about, and we certainly have people on methadone who drink. I can't think about anyone who's requested withdrawal management. I think my first choice would be gabapentin, if possible. I mean, we know that there's sedation and that there can be risks, but it always feels safer to prescribe gabapentin than the kinds of doses required. I think a lot would depend on someone's overall stability, but if they've got enough AUD that they need support with withdrawal management, then I would be thinking about some kind of supported setting, whether it's like a withdrawal management setting if you really felt that you needed to do benzos. I think that would be my comfort zone probably overall. I feel like there was a, yeah, 1, 2, yep. Sorry.
So for me, as a freshly graduated training 2 years ago, I was probably 3 months into practice at a young gentleman coming to the clinic. About 35, drinking 85 to 6 standard drinks a day, fully functional, working, and taking 9 days off work and had a tight timeline to kind of solve this whole alcohol problem. And again, through my training, like the cause is something very on the road. And it's really important to remember that validated is an inpatient tool, not an outpatient tool. And very rigidly going through the criteria for this gentleman, he only met great medical. And so I said, with absolute confidence, I think you're a great candidate to gap on the head with a whole treatment option. So prescribed pretty liberally, just a 300 TID to start, up to 600 TID. Taper out acne based on the symptoms. And then, of course, this gentleman did go home and season from this point on the weekend. So just to be careful about using an inpatient tool in the outpatient setting and the implications it can have. And while I think it is important to be cautious about prescribing benzodiazepines, especially in situations where maybe there's comorbid opioid use like methadone, you also want to think about the context again. Well, supporting a gentleman had his wife home. Really not a situation where now I would hesitate to prescribe outpatient benzodiazepines.
Yeah, thank you for sharing that. And we use these tools with the best of our intentions, no crystal ball. But thank you for sharing that. I think there's a question here. Yeah, and then sorry, I'll come back to you. Does anyone else want to answer that first or take a stab?
I think
Multiple attempts at doing withdrawal management, some kind of supported withdrawal management, but not being successful in maintaining their abstinence or reduced drinking.
great question. This comes up relatively frequently at our clinic. And what we do is kind of have a deep dive and conversation with the patient and look at what things are working and what things are not. There are sometimes things at home, triggers, personal stressors, lack of housing, all sorts of pieces to the puzzle. But we try and have that conversation to see how can we adapt this, perhaps throw on a Campersate after they've ceased drinking to kind of help get them through that. But it's something that we have a kind of forthright conversation. The other thing is I want to highlight sometimes it takes a lot of kicks at the can. It took me quite a few. And so just don't give up on some of those folks that it's like, here they are again, right? And sometimes it takes a lot of tries. That's my 2 cents.
Yeah, I think, all the things that you probably would do, right? Where are they going to after discharge? Should they be going to a residential program? What else needs to change in terms of their supports? Are we looking at their mood, at mental health and social situations? I have had some experiences where it seems like people keep coming back asking for benzodiazepines. And that's a challenge because I hear you, Adam. Sometimes it takes multiple attempts, and sometimes it feels like people are coming back looking for benzodiazepines. And so if I've been down that road a few times and it really doesn't seem like things are changing, I say we're not doing this anymore. We've got to do something differently because I worry about what's happening with creating a benzodiazepine dependence. Are they not using them? Are they keeping them and then potentially drinking? And I don't want to. It sounds bad to say I don't want to reinforce that. I feel like it's not working, and it's not. If it's not helpful, then we need to do something different. Yeah, I missed you before. I'm really sorry. Yeah. Please, just say it really loud.
She gave them the ultimatum, quit drinking more amount. Tried to stop abruptly in that she was giving him an ultimatum because I would have told her what a bad idea that was. And nobody knew that she was telling him this, and she didn't know. She didn't know that he was, I was for having a seizure. 25 years old, first seizure. Gone.
Yeah, that's heartbreaking. Yeah. That's a really important reminder, and I'm sorry for you and everyone impacted by that loss, but thank you for that message. Any other? Yes.
I just wanted to, if you were to set up a date detox in a restaurant area, I'm just wondering what would be the bare minimum that you think you would need to say. I'll just give you the context. So I work in rural Ontario. The closest withdrawal management bed would be an hour and a half drive, but there's no public transportation, so people have to try and plan that out. And I have a number of patients who, maybe they have seizures or maybe they have high-risk seizures, and they have to go to these times that home detox with them tends to be the only option. And they'll be like, if you don't do this, then I'll just go cold turkey or whatever, but they absolutely refuse to go to. And I always feel uncomfortable. We do all sorts of safety things, but it'd be really nice if we could set up something. But like, what's the minimum? We have medications, but like maybe 7 hours, maybe one nurse. Like, what is the minimum that you need to feel like it's actually a day detox?
Would you be able to think about doing it as a room in your hospital?
It would be in our clinic.
Mm-hmm. Mm-hmm. Yeah. I mean, I wish that there were more capacity to think about how to use hospital settings more flexibly, right? They'll bring people in for infusions or day programs. There are other outpatient programs like dialysis clinics. So I think being able to think outside the box is really great. I guess my minimum, and then I'm curious about other people's, 8 hours probably. Like the idea of 12 is pretty great. 8 hours, but then the person needs to be in withdrawal when they come in, right? So sometimes when we tell people to come in for 10, they actually had a drink at 5 and they're not going to be ready to start their withdrawal until sometime in the afternoon, and then you're going to run out of time. So obviously, like setting expectations, having that. I think you don't need like one-to-one nursing, but you need someone who can check on that person regularly. You don't need to do a CWA protocol if you're bringing them in. I would probably load them and then do PRN. So you need someone who can manage them. So you need enough of your benzodiazepines. I'm wondering if you would want to have IV access in case they're really doing poorly. I don't know what you would do now that I say that, because you're not going to have IV benzos in your family medicine clinic. Just thinking about sort of facilitating access to sort of emergent care if you need to. A relationship, which you already have, obviously, to emerge in case you need someone to transfer, and understanding that that's the case. Wi-Fi, a plug, a charger, like, some instructions or some access to, like, food and drink and those kinds of things. And you need to be able, I guess what I would say is you can't do everything that you're already doing in your day and then just think about like popping in and that it's only going to take kind of 2 minutes every couple of hours, because you have to be a little bit more prepared to handle the unexpected, right? And we've all seen that. So you don't have to block off a day, but you need someone who has some allocated time amongst the other things that they're doing. And then, knowing you already would be connecting this person to whatever other kinds of supports there are in terms of community, peer, mental health. So yeah, I guess like it doesn't have to be a bed, but a reclining chair and a room and a person in 8 hours. It's past 5. We're so grateful that people have stayed. I'm especially grateful to Adam. I just want to say out loud how generous you've been with your clinical and lived knowledge and expertise, and thank you. Yeah. And thank you for sticking it out through the whole day. We hope to see everyone. Resources. We printed all these resources, so people have to take them. So please come and grab them. And we hope to see you later and tomorrow. Thank you.